Good evening, everyone. My name is Sharon Moreno, and I'm a family nurse practitioner. I practice out of the great state of Texas via telemedicine and see patients locally in the Rio Grande Valley. We are Gold Rush Health Solutions, and this is Let's Talk Health. Our topic tonight is navigating levels of acute care in the acute care setting. I do have a special guest tonight. I have Efrain Sedillo-Guevara, and I would like to formally introduce him. Actually, I'd like for him to introduce himself. Efrain, introduce yourself.
Hello, everyone. It's a pleasure to be on your show, and I'm very happy to participate in giving people back to the community in knowledge. So, my name's, like I said, is Efrain, and I've been a nurse for a long time, more than 2 decades. And I started in healthcare in the 1990s, and I worked myself up from bedside nurse RN to a master's prepared double specialty, both business and nursing administration. Right now, what I currently do is I'm a supervisor for the federal government in um, navigating patients in healthcare. So my background is everything in acute care that you can imagine, taking care of patients through case management in hospitals for almost 20 years. Um, that passion is something that still burns deep in me, and I help others, especially family and patients, navigate the very meticulous and very hard to navigate acute care.
Absolutely. And Efrain and I have known each other for many years. So I've been in healthcare for 21 years. When I started back in the hospital, Efrain was already doing case management then, and he was a great mentor of mine and somebody whom I enjoyed working with. Always shared his knowledge, and like I said, was a great mentor of mine. And speaking of Valley Baptist, I have a comment from Jenny, and she says, "Hi, Sharon and Efrain. Jenny also worked with us back at Valley Baptist. So we have a great community of people who have served our Valley population. And Jenny, Efrain, and myself were three of those people."
Correct. So, some of the topics that I wanted to discuss with your viewers and everyone who will eventually see this YouTube channel, because I'm pretty sure you'll be successful, and this knowledge needs to go through the whole country, is how and why I ended up in a hospital. The most basic, and when to go. Most people go to a hospital emergency room. That's the first route. And they go because they have something that their doctor at their local clinic or provider cannot handle in a outpatient setting, or it's after hours and they need emergent assistance for whatever um, disease or illness or ailment that they have, or accidents, etc. But once you're in the hospital and you're admitted, that's where all the questions start. So, one of the first things people don't understand is the vocabulary, the lingo, the medical lingo that starts happening the minute you step foot. I need stat X-rays. I need stat labs. Um, there could be let's just say a DVT on his right leg. We start using acronyms and people start getting a little uneasy. So that's the first, I guess, icebreaker that I would like to address with your viewers, is that there's a lot of medical information that you hear, but it's not necessarily meant for lay people. It's meant for clinicians to talk amongst each other. So it's
Sure.
important to always be knowledgeable of why you're in a healthcare setting, such as a hospital, and ask some questions. So I think the first bullet point that I wrote down was, am I going to be staying overnight, or am I going to be observation for 2 or 3 2 a night or two. So those are the most important things, and you're scared and you don't know why. So I don't know if you can relate to this, Sharon, or our viewers, but most people don't understand what merits an admission. One of the factors and one of the biggest players in why you're going to be admitted is your disease process. And it could be something that, needs a doctor and a acute care setting, which has labs, x-rays, more expensive machines that can take diagnostics for you. That's usually when they admit you, because there's a disease process going on that may be life-threatening or cause serious injury to you. So that's mostly the reason why you get admitted into a hospital. Of course, there's a lot of other emergencies that happen, car accidents, unfortunately, or just, violence. People suffer a lot of wounds, whatever, from violence, whether it's healthcare workers or police or just your lay person. That's something that will merit an admission to a hospital. And then there's people like me, or people like me in the past, with my former job as a case manager, nurse case manager, that will be the navigator of your existence in the hospital until you get discharged. And there's things that occur that sound and feel kind of out of touch with what normal people outside of the healthcare setting experience. For example, you'll start, hey, you need to sign here. That's usually, they're verifying your insurance. They're seeing, verifying nowadays, the state of Texas and some other states, even your legal state, residence, etc., citizenship. That's even part of now your hospitalization questions. That's a whole other topic, but those are things that are happening while you're staying there. They're discussing with your medical team how long they think you're going to be there and how sick you are and what level of care you require. So depending on your diagnosis, that's where you're going to end up. So let's just say I have abdominal pain. They have an appendix that they notice that in CAT scan that is inflamed, almost going to burst. Well, my level of care would be a surgical floor if there is no complications. So those are some of the things that most individuals will have, is just the why I'm here. And it's important to make sure that who you're asking questions is a correct person. It's your provider, and not anybody in scrubs. People are your provider. Make sure it's up. You ask those questions. Are you my healthcare provider? Are you the one that gives orders, or are you an attending? Are you a consultant? Why are you here? Those are valid questions. You're a customer. So as a customer in a facility that you're paying for, or your insurances, those are extremely valid questions. Why are you doing this test to me? Why do I need to have it done 6 times a day, for example? Sometimes they order ammonia levels, which they don't do anymore.
Absolutely.
But let's just say another exam, my hemoglobin hematocrit. Why are they doing it every 4 hours? Maybe because you're anemic. What is anemia? We have to talk it down. We assume, a lot of us clinicians, that your average individual knows what these disease processes are, and that's not the case. There's a lot of disconnect. There's a lot of knowledge deficit, as you mentioned, Sharon, before this live recording.
Segment, yes.
Mm-hmm. And that's very important that we educate the community on reasons why they have to go to a hospital, which is sometimes life. It's a matter of life or death. So we don't want to get to that point. There's people like you that do preventive care. People should be always on top of their health. We don't want to get
Absolutely.
to the point where you need to hit an acute care setting, which is a short-term acute care hospital. That's what we call hospitals that are short-term. They are short-term. They usually are created and were created just to stabilize, treat, and move you through. Um, and that's also another lack of information. People don't stay or will not be staying at a short-term acute care hospital until they are 100% complete, because unfortunately there's days attached to your insurance, etc.
And kind of piggybacking off of what you stated, Efrain. So for every diagnosis, like in the situation with your appendix, there's an allotted days that the patient typically would stay in the hospital. So the patient can say, hey, in this situation, how many days am I looking to stay? And these are guesstimated days. These are never absolute days. People can have complications and stay longer, or, do really well and leave quicker than the expected time. Of course, we always like patients to be home and leave sooner than they have to leave, if that's possible. But unfortunately, sometimes people do stay longer than they have to. And Jenny says she has two comments. She says, I've been a patient multiple times, and luckily I understand the reason for staying. But yes, the people in general, but for the people in general, it was scary for them not knowing or understanding the reason at times. So again, communication is a huge must. The thing I've noticed is that sometimes people are a bit shy. They tend to not ask questions. And we don't always know. Sometimes with their nonverbal communication, we can tell that they may be a little confused, and we can, go back and explain a bit more. But some people either may have a confused face all the time, or simply may not show that they are a bit confused. And so we may not know that that's a situation, and we may just keep rambling on and move right past that.
Yeah, so if you have to be a patient and you know that you're going to be a patient in a hospital, let's just say it's scheduled before time that you need surgery and you're going to be inpatient at a hospital. It's always important to have your next of kin who makes decisions aware that you're going to be there. If you suffer from a chronic illness such as, and let's just say, in my personal life, my mom suffers of end stage non fatty liver disease. So she's good, but when she's not good, and it can happen a split second, she can't make decisions because, that type of disease process alters her mental status. So if people have chronic illnesses that their mental status is affected, it's important that they have a support system um, that really was below on the lower bullet points, but I'm going to bring them up. You may want, no, you need to actually have a plan. You have to have a designated medical power of attorney. That's a very good idea because the older we get, there's disease processes that will be affecting our mentation, our cognition, Alzheimer's, Parkinson's, and just old age dementia. So things need to, the tough conversations, those are what I really wanted to point out. We need to have those tough conversations and not be in denial that we're not going to get old and we're not going to be forgetful and that we're not going to, die eventually, but have a plan so your wishes can be respected. So many times, like you said, these patients are unaware of what's going on because they're mentally checked out due to their disease process, and that's where the clinician, the provider, and the nurse and the other healthcare team has to make a lot of assumptions, and that may delay the accurate treatment plan for the patient. You did mention that based on the diagnosis, there's a certain days allotted for people in the hospitals, and that is true if you have an insurance or medic or federal insurance. it's what we call the DRG system, and now it's bundled. It's a whole package of money that they guesstimated in the Centers for Medicare and Medicaid. And let's just say they allot certain days for the average person with that disease process. And the hospital's job is to, unfortunately, like we said, it's a private company. So their job is to maximize the profit while they keep you the least amount of days there, because that's how they make their profit. Ethically, as clinicians and as human beings, we don't focus too much on that. There's people that's their job entirely to focus on. I want to say case managers in the hospital. Part of their job is to assist with the bottom line of the hospital, but it's also unethical to push people out, as people feel. Some people have felt that they've been pushed out before they're ready. So people have rights if you have Medicare, Medicaid, and you have rights that now they inform you. You have a right to rebuttal your discharge if you feel that you're prematurely discharged. But yes, going back to the allotted days, there are now team conferences between the physician or mid-level and the nurse and maybe a case manager that are doing the rounds every day in certain facilities. It's not just one company. I think it's best practice all over. It used to be mostly in the tertiary centers, but now all of the hospitals have adopted those transition of care meetings right next to the patient or right outside the room, or a designated area where they have like a board, electronic board with the patients and discussing, the case. Someone like me as a case manager, a nurse case manager, my input to the team would be where I can assist in breaking the barriers for the patient to move out of the hospital. So barriers for discharges occur. For example, a patient's undecided of where to go next when they need that type or level of care. Mm-hmm. So it's scary. Like we said, it's already scary to be in the hospital, but then to decide, your team is recommending that you go to a skilled nursing facility at a nursing home. Well, that's a very taboo subject in this area, and especially for people of that age. They think they're going to get locked up and forgotten. But actually, skilled nursing facility at a nursing home is short-term as well. They may recommend intensive rehab at a rehab hospital. That's also acute care, lower than the short-term acute care hospital, maybe for a week or two, because they have let's just say a polytrauma event where they broke multiple bones during a motor vehicle accident, or now we call it motor vehicle crash. The other option would be long-term acute care hospital. And long-term acute care hospitals are, by definition, the same quality and care that a short-term acute care hospital gives, but is paid out for a length of stay of 21 days minimum. So those would be catastrophic illnesses. And there's also such a thing as a catastrophic case manager. So catastrophic illnesses are, let's just say, you had an anaphylactic reaction to X chemical exposure, caused you to have a respiratory arrest, caused you to have some sort of brain injury. You're still on a ventilator. You're young. And when I say young, I'm talking about 60 below or 65 below. You're still young enough where you can have an extended life. And that's the place where we would transition patients that have a potential for good outcome, but their hospitalization will be prolonged. And that's also another scary um, topic to bring up because people feel safe in those four walls in the hospital. They think that the hospital facility is a safe place for them, and I understand, and we all, like some of our viewers have mentioned, um, being in the hospital is different for everyone. Us in healthcare, it could be, you know, we know we're going through the motions, but someone who has no inkling in the healthcare industry, it's a safety net, just like a baby with a baby blanket. You know, they don't want to let go. If anything happens to me here, they're gonna resuscitate me, keep me alive. I'm gonna stay here forever. So they kind of, hesitate to transition out, and that's something your medical clinical team, a case manager, a navigator. We're also called navigators now. Will navigate you to the appropriate level. It's my job, has been my job, to talk some um, sense. I don't want to really say that word but I did, but talk to some sense into the patient and say, you know what, this is the logic behind it. It's not because we're trying to get rid of you. It's not because, etc. It's because you're going to have a prolonged placement and you need to be there for that period of time. And there are the resources and the medical care there to take care of you, because we need to make room for the other 100 people that are coming in through those doors. There's 180 people coming through ERs, up to 200 depending where you live, through that
Yeah,
ER, and a good chunk of them are getting admitted. So it's like a revolving door, like a restaurant. You need to finish your meal so next person can get
yeah,
attended.
absolutely. And
Oh,
we saw this a lot during COVID time, where
mhm.
there were a lot of people going into the LTACs, where we had a lot of people of all ages, but especially a lot of young people who were having catastrophic events, who were being sent to the LTACs, trying to, recuperate, being there a year plus, trying to get off of the ventilator, and then rehabilitate them to walk and live some sort of normalcy.
And some of those people have yet to recover, and
Yeah.
some of them our colleagues passed away, and
Yep.
some of our colleagues are incapacitated for life and are unable to be nurses or doctors or any part of the healthcare um,
Yeah.
professions that we have. And it was, a trying time. But I will say, in regards to the LTAC, the government made a special waiver because there was not enough hospitals, short-term acute hospitals, to take care of the COVID um, victims. So they allowed the LTACs to serve as a short-term acute care hospital and long-term acute care hospital at the same time. So they were being directly admitted to the LTACs, and all insurances and all federal payer sources were paying, because of the waiver that the government made, that yes, we will pay you, excuse me, to take care of um, this person, because it was a complex disease. It still is. Well, not it is still complex, but not as serious as it was back then. Um, and they had to be there sometimes, like you said, up to I never saw a year, but I'm assuming you did. Um,
Hmm.
I know that there's a lot of people in the healthcare industry that had to not work anymore as a healthcare worker because they were compromised, and for whatever genetic reason they were susceptible more so than others. But that is a good topic, which is the long-term acute care hospital and what it served during COVID. It served both roles, both short-term and long-term acute care, which is very interesting, and probably I hope we don't see that again. um,
I agree.
I hope we don't get another a pandemic like that in our lifetime. But
I
um,
agree.
it is
It's a
something
tough
that
time.
they had a dual role during the pandemic. But right now, as of 2025, they're back to operating as normal, which is for catastrophic illnesses with a good rate of recovery. So,
Okay.
one of the other things that I wanted to discuss tonight was once your physician or your provider tells you a diagnosis, it's important as a patient to know the seriousness of it. Prognosis, that's what we call it in our medical world. The prognosis, is it good? Is it bad? Am I able to live with it? Or is it something that, I have a short amount of time to live? So some of the statistics that are out there is that the average national lifespan of an American or anyone who lives in the United States of America is about 71 to 72 years of age. So let's just keep that in mind. So most of us are already, well, me, I'm almost 15 to 18 years away from that. So you've got to also be cognizant of where in your lifeline or span of life you are for realistic expectations. So if I have a terminal illness and I'm 69 or 70, tough conversations once again. Doctor, my prognosis, good or bad? I'm talking about being 71, being 72, or like some of our viewers can agree that are in healthcare, that we have the people from the silent era still around. And those are the individuals that are in their 80s and 90s. And is it realistic for them to have an additional 10 years, do extremely hard diagnostics, procedures, for them to endure that type of, sometimes it is painful for whatever intervention they're doing, puncturing your lungs, resuscitating you, keeping you on a ventilator. You've got to be aware of what you want and where we are at the lifespan. Once again, at the hospital, they will mention one of the topics that I wanted to discuss was do not resuscitate. And it is very common for us to throw that acronym around in the hospital and without blinking twice. But it is a very scary term for a person who is not healthcare, who's not in healthcare. So it means do not resuscitate, and the question is when. So you, as the patient, have the final decision. If I am ever in a situation where I am dead, I'm medically dead, whether it's a car accident, whether it's an illness, do I want a medical team to resuscitate me? And once again, it goes all the way to where am I in the lifespan? Do I suffer from chronic illnesses? Am I a very healthy individual? Am I a triathlon athlete? Am I in my 30s and 40s? I have my kids to take care of. So those are all factors in making that decision. But it's something I want to throw out there because they will be talking to you about in the worst case scenario. And it's happened with very healthy people. I always remember a case, and someone went for a colonoscopy, had an anaphylactic reaction she was in her 30s, had an anaphylactic reaction to whatever conscious sedation they gave her, and she flatlined. And she was a DNR, So it is sometimes very hard for us, a hard pill to swallow, but some people know what they want. Could have she come back from that massive anaphylactic shock, heart attack? And this was in the 90s. So this wasn't 2025. This was in the 90s. I think she did
Sure.
the right decision because there
Yeah,
was
that
not,
was, see, you can't go wrong when it's your decision. It's her decision.
it was her decision and it was a very painful one. It was a young woman and it was painful for all of us, but she knew. And well, that was not the reason she was admitted though. She had she was admitted for maybe a chronic illness, but the colonoscopy procedure is what catapulted that heart attack and respiratory failure, cardiac arrest. And she knew that she preferred quality of life versus futile care. So other terms that we're discussing now, we're weaving into other terms. So it's important that you are aware of quality of life. And what is quality of life? Some people have had their limbs blown off, and I'm referring to people who have been in the military, and
Yep.
and they function perfectly well without legs. They have prosthetics, and they have a good quality of life. You know, they have families, they're working, etc. So it's very tangible. It's what
Very
is
subjective.
mhm, subjective as well, because
Mhm.
someone with no, some other people will think, well, hell, if my legs were blown off, I don't want to live. An athlete, let's just say. Um, but other people, they push through and they overcome. However, quality of life sometimes is a topic that is discussed for people that have end of life um, illnesses, cancers that are stage 4, um, end stage Parkinson's, end stage dementia. Those diagnoses will eventually, you will succumb to respiratory failure because you forget to breathe. Um, those are more the quality of life discussions that we discuss with families when they're extremely elderly with multiple illnesses, and they are being kept alive artificially. And that's when your that's when it's important that families have those tough discussions about their relative. Mom, is this when is when do you want us to let you go? Or dad, or sister, or brother, or husband, or wife. um, a lot of people are single. A lot of people are single. um, a lot of people have their best friends are their family. So family is not necessarily someone by kin. It could be someone that
Mhm.
dear and near and are family in life. So they can also make those decisions for you if you give them the medical power of attorney. So it's important that you review all that. I'm talking so you won't be so stressed out at the hospital because they will be asking you those questions that do not resuscitate. You have to make those decisions. Think about them. At least let them percolate in your brain. Um, and that medical power of attorney, I wanted to note, that differs from financial and durable power of attorney. So many people confuse both of them. Um, Here in the lower Rio Grande Valley, um, I've seen patients and family members assume that a person can go cash a check. Let's just say they were still receiving checks the old school way, and the person that's making medical decisions can also cash their checks, which is there's frustration. And I go, well, that's two different things. And then we have to connect them with maybe a a law office, or I'm forgetting the other name of the person that can stamp legally. Forgetting that term, but
A notary public.
there you go, a notary public. um, that vouches that person can do that for you. So those are some things that people have in their mind. I can't be impatient. I have things to do. I have bills to pay. I have a job. I have also, you know, prepare for the worst is what we need to have in mind. And I'm not saying that the worst is happening or catastrophic, but prepare for an illness, you know,
Mhm.
because you never know. I mean, you can have a very sick moment and you're going to have to be out of work. You're going to need to have that maybe insurance continue to be paid. Who's going to pay it? Is it going to be your AFLAC? Is it going to be some other type of insurance that's going to pay your insurance? And there's gap insurance, you know. All those things are things that people oversee sometimes because we're busy in life working, but it's important to address because illnesses are very expensive, and especially hospitalizations. Um, the average hospitalizations for 3 or 4 days are sometimes in the six figures that your hospital or your insurance pays. Usually, insurances pay a negotiated rate, depending if that's the destination preference destination of that insurance. They negotiate a rate. My Blue Cross Blue Shield, my X insurance, um, they will negotiate a rate because all my patients go to that facility. So also keep in mind when you're in a hospital that you have your affairs in order about your insurance that is current, that you have something or some way of paying for a catastrophic illness. And what happens when you don't have anything, no insurances? Um, Ethically, we're not supposed to ever turn a patient away based on their insurance, but there's only so much the hospital can do. And I'll revert back to what a short term acute care hospital is. The purpose of a short term acute care hospital is to stabilize and treat. So if you're uninsured and there's an illness that you have, let's say diabetes, and you were admitted because you had a diabetic crisis with maybe a blood sugar of a 800, 700, TKA, diabetic ketoacidosis, well, the hospital will stabilize and treat you. Unfortunately, the aftercare and the continued care is on the onus is on you as an individual. So it's important that you have or some sort of method of at least getting preventive care, taking care of yourself, checking yourself with your PCP, or have, walk-in options, or like your platform that you mentioned, that you do telemedicine. Those are other options for
Absolutely.
that are uninsured. So maybe you can speak to that about if you uninsured folks reach out to you, what is it? How do you treat them?
I see a lot of uninsured folks. So yes.
Okay, so there's options like I said mentioned. There's I'm going to put a plug in for you. Gold Rush Solutions would be a provider that can see you at a negotiated rate that is affordable and maybe
Absolutely.
prescribe medication that is generic
Yep.
and to that's affordable and without breaking the bank, because economy is hard for a lot of people for whatever reason, and it's important that you have your health controlled. At least you know where you stand. Uh, a basis of reference base. I know that I'm a diabetic, and this is what I need to do: take my meds, eat better, exercise, sleep, whatever. High blood pressure. In order for it not to go crazy and for me to have a heart attack or plug up all my arteries, I may not have insurance, but I'm taking my antihypertensive that is generic. I'm
Yep.
exercising and I'm checking in with my, let's just say I'm plugging you in again, my Gold Rush provider, or
Yep.
whoever your provider is, um, because it's important. And I know there's in the most um, impoverished areas of the country, there is a lot of mid-level providers that provide a reasonable pay or charge for a health screen, affordable labs, etc. There's ways around not having insurance if you truly cannot afford it. But if you can, make sure you don't opt out of it from your employer, or if you're self-employed, make sure that you always carry that insurance and you have a way of having it paid in case of a catastrophic illness. So
Absolutely. Jenny says, information for anybody that goes to Valley Baptist in Brownsville. I believe there is one or two notary publics there and a chaplain that can help as well with directives to physicians. Anybody that comes into Valley Baptist, I know for sure the do not resuscitate, healthcare proxy, all of that stuff is going to be part of your packet. I remember patients would be like, I'm not dying. And I would tell them, it has nothing to do with your status, your healthcare status at this moment. It has something to do with where your healthcare is going. So whether you're doing really great now or not so great, this goes for everybody. So it's
correct.
for everybody.
It's a
We also,
industry standard.
yes,
So an industry standard for all short-term acute care hospitals that are in compliance with federal regulations and laws is to provide that information and those services for all patients. So that's why they do that.
absolutely.
Another thing I wanted to mention was one of the topics that is very, and I know we have 15 more minutes, so I'm going to make it really quick. There's a couple more things that we can talk about, but we'll probably have to leave it for next time.
Okay, we can have you come back. Don't worry.
I may need my crew with me, so
Okay,
we'll get something going. But
sounds good.
something that people need to know are what are extraordinary measures of life, and what does that even mean? It means keeping you alive when your body cannot sustain itself. So, extraordinary life measures, believe it or not, is dialysis, is a ventilator, is a percutaneous endoscopic gastric tube that we have, which is called a PEG, to feed you because you're unable to swallow. Or, worst case scenario, TPN, which is basically liquid food going and nutrients going through your, not through your vein. I think they do it now through a port. And those are things that are extraordinary. That means it's not normal and they're not natural. And once again, tough decisions, tough discussions that you and your loved ones are going to need to do before, you're in that position where you need to be in an acute care hospital. Like I said, preparation is everything. Conversations about health are important. When you get married, let's just say those are milestones in your life, or you hook up with someone. Sorry, I didn't mean that word. When you partner with someone, what are your wishes? What do you want? Those are normal conversations we should be having with our partners, our spouses, loved ones, if you're single. Because do I really want to be in a ventilator for the rest of my life? If my brain is dead, do I really want dialysis, or do I just want to, if my kidneys fail and I'm of a certain age, I'm okay with passing, you know? Once again, those are extraordinary measures of life. You will hear that all the time in a hospital setting. They will mention this person um, is on extraordinary life measures, or they'll give you something to sign and say, I don't want any of that done, extraordinary measures of life, and it includes those things. We already mentioned the other levels of care, which were acute, the tough conversations, medical power of attorney, mental capacity. Very important. God, oh God, we need more psychiatrists and more mental health practitioners in our hospitals, and judges. So a lot of the elderly, as we've met before this session started, we discussed that a lot of the patients are unable to make decisions because of their advanced disease process. So when there's nobody around and they're alone and someone needs to make decisions for them, but is not legally their medical power of attorney, this is where we get into that gray zone. Well, let's get the mental health authority of the state or the county or whoever come and determine if that person has mental capacity. So I'm going to break it down really brief because it's not my specialty. I think a psychiatrist would speak better towards it, but a psychiatrist basically talks about, yes, the person clinically and based on my medical training cannot make decisions on himself because they have a disease process that impedes that. However, we confuse mental capacity with competence. Remember, a court of law will say he was competent or was incompetent when they, let's just say, murdered someone. They pled insanity. So the judge, by law, is the only one that can make that decision. The judge will make that decision based on the clinical advice of a psychiatrist. So even though the psychiatrist said he has no capacity, Sharon can walk and get out of that bed and go to the downtown store she wants. I can't hold her against her will. Only a judge can make that determination. So that's where it gets tricky because people think, oh, he's incompetent. Well, only a judge can make that decision. They have to take that special order to that recommendation from a psychiatrist, a section, what we call a section in Texas, take it to a judge so they can sign off whatever recommendation. And they usually do. I have 30 plus years, have not seen a judge say, I disagree with the psychiatrist. But it's just the process of the law. So very important also for us healthcare clinicians to know the difference between mental competency and capacity. Psychiatrists will only determine capacity. Those records will be taken to a court of law or judge if a family wants to take over that person's medical power of attorney or financial power of attorney. So those are topics that come up in an acute care hospital often, and there's a lot of confusion because that's not something we get trained in, but also is a subspecialty of, like myself, a board certified case manager that goes to school especially, or special training to know the differences amongst all of those. If you are mentally ill, what happens? Well, obviously you're mentally ill. You may not know you are, and you're in a crisis, right? Or you do know you're mentally ill. You do suffer from schizophrenia. You suffer from bipolar, and it's unregulated. Will the local hospital keep me there? The answer usually is no. They're going to stabilize you. They will consult with the psychiatrist and then transfer you to a mental health facility, which is Also, it can be acute and can be long term. But just for the sake of time, I'll just say that um, the only mental health ward that I know of in the Valley, um, wards are the one here in Harlingen for geriatric behavioral unit in Valley Baptist. McAllen, we have South Texas Behavioral, which actually is North Edinburgh, or sorry, North McAllen, and DHR, Doctors Hospital at Renaissance, that also has a mental health facility. So they transfer them from the ERs directly to the mental health facilities when they're um, unregulated, their disease process, mental disease process is unregulated, and it takes a while before they get back to normal with the correct treatment plan. So things to know about being admitted: you have the right to say yes, and you have the right to say no about your plan of care. This is not a communist country. So you're not in a communist country. When you're in the hospital, you're able to make decisions just like you do shopping at a dealership. No, I don't want that. Yes, I do. So don't feel compelled that everything that is suggested you have to do. Sometimes you want to take things at a stride. I don't want everything done right now. I'm sorry. It's not that important. If the physician says it can wait, it can wait. And you make those decisions in an acute care hospital. I myself have done that, with cholecystitis, which is gallbladder inflammation. I chose not to have surgery, um, and treated it by a better lifestyle, and so far so good. So those are options. You don't always have to have a surgery, because surgery in itself is also business. So any questions that you may have for me, Miss Sharon?
No, I am so happy that you joined us today, and I'd love to have you back again.
Yes, there's a lot more that we can discuss. We had, for example, futile care was one of the topics that we can
Yes.
definitely um, expand more on, especially because in the era that we're living, um, like I said, that we're not maybe sometimes aware of the lifespan cycle of a human being. And there's reasons what we call futile care, because regardless of what we do medically, clinically, imminent death is going to happen the minute they don't give you that, I don't know, IV pressor to keep your heart going.
Yep.
um,
I
and those
really
are
like that you listed the age that, or the expected life
span of them.
expectancy, if you will, because it really puts things in perspective. Like literally, I was like, how
Hmm.
many more years do I have? I mean, it's crazy, but people really do need to think about these things and start, I guess, living. Really, not that I haven't been living, but definitely start living a bit more. And I enjoy absolutely what I do, but the clock is always ticking.
Correct, and that's why work-life balance is important. It's important to take care of yourself. It's important to educate our youth. I wish that we could educate youth um, sooner about these topics, so they can be. I think these are very basic topics. I think this should be taught maybe at a high school level, or junior high level, with the health care classes that some of them get, or just a mandatory class, just so people could start, you know, percolating, like I said, in your brain what you want later in life. And it also will be a determinant of how you live your life. Will I live a life of crime all my life, go to prison for 20 years, come out at
Yep,
55, and I've only got 20 years left, you know?
yep,
Many people don't make bad decisions because they're unaware of how fragile, how short life
yeah,
is. So,
yep.
once again, important conversations. The hospitals are are good are are good places to be if you need to be there, but you have rights. And like I mentioned, a laundry list of things that you should be asking and thinking. Um, and it's for your best interest in the long run.
Absolutely. And there's other topics, that you just kind of opened up, things like hospice services, talking about your end of life, that I want to discuss, also provider services. I know a lot of people have had questions about if I get provider services, can they take my home away? So, I want to discuss things of that nature. There's just so many other, resources in the community that need to be expanded on so that people have that information.
Hmm.
But yeah, I think that that this definitely started that opened up that can of worms, and we definitely need to discuss that a bit more. And B says great information. Thank you, B, for joining us tonight. It absolutely was and is great information. We're going to continue to discuss these things in depth. And guys, look, this is my first special guest. If you know somebody or you yourself want to be a special guest and you have a medical topic that you want to discuss, message me. I'd love to have, special discussion, special guests regarding health related topics. We're here to educate the public. We want people to know things that are important and that matter. Again, if there's particular topics that you're interested in and you'd like me to discuss, again, I'm happy to discuss that. With every session we do, I always put the legal disclaimer up, so I'll leave that up for a little bit. In the meantime, we say a last few words, but that's essentially that. What else you have, Efrain?
Well, just piggybacking on what you said is, you know, it's life. We've got to live it to our fullest. We're just here to provide education to the community because we have a passion and a desire to see our loved ones and our neighbors be make informed decisions. In our case, since we're healthcare clinicians and workers, we want to see them make and have positive outcomes. In my case here, I was talking about an acute care hospital setting, but in all levels of care, life is beautiful. Um, there's many stages of it. Even death can be beautiful.
Absolutely.
You can have a peaceful, tranquil death and have a quality of death. So topics that people do not talk about instead of, you know, just living in segues, busy with work, busy with this. I'm ignoring my ailments, etc. But sometimes people react mentally, and that's a way of safeguarding themselves from reality is by keeping themselves away and distant from those tough conversations, like you said. But it's a pleasure to have joined you. Um, I'm so happy for you. I've seen you since I call you my child. I saw you very young. You were always asking questions, very interested. You took the feedback. It was hard to say goodbye to you. I'm very happy that you are in this role in your life, taking care of patients, and some of the most patients that have the greatest need are impoverished populations. So I applaud you. I commend you. I will always support you. And if you need anything else in regards to a topic of navigating healthcare, I can and I will assist in any way I can.
Thank you. I appreciate you very much. I definitely want you to come back. So let's plan something in the near future and we'll go from there.
All right. Thank you to the viewers and to you, and we'll see each other soon.
Thank you guys for having us tonight. We are Gold Rush Health Solutions and we will see you next week.